Hello, my name is Brian Bircher. I'm a CPA here in Kirkland, Washington. I have focused on working with dentists for the last 40 years, whether it be uh, their accounting needs, their tax needs, their consulting in the dental area needs. I teach webinars, classes, etc. The purpose of today is to take my 2 hour webinar on key factors and try to condense it into about 30 minutes so that you can look at this at any point and remind yourself of this. And also feel free to sign up for my next webinar, which will go into more detail and more examples. But again, today it's on the key factor report that equates to like a physical that a physician would give or an exam that you would do. This is basically an exam of your practice. I encourage all of my clients to do a key factor on themselves. We do quite a few for our clients. We've taught several other clients and they do their own. It's basically how to monitor how you're doing. It's a one-page document that's got about 16, 17 calculations on it. Half of them are from QuickBooks, so pretty simple. Today is to try to give you an idea of what they mean and how important it is that you look at these factors together as a whole, not one factor by itself. For example, overhead. Overhead, if you look at it just by itself without looking at some of your production key factors or your accounts receivable key factors, could be misleading as far as how you would approach things to do. The key factor report consists of financial statement key factors, accounts receivable key factors, key production related factors, new patient factors, and then we'll end with a key factor report example. On the financial statements, that's basically overhead. That's from QuickBooks. So number one, we encourage you to have your QuickBooks designed in a way that you can get to these categories quickly. You can get to your total overhead very, very quickly. It should only take you about 5 seconds to see what your total overhead is if it's designed and set up correctly. That will save you an immense amount of time. I will also say one tidbit on the financial statements. Everything here is in percentages. You should first look at what is the percentage that you're allocating to the particular category versus dollar amounts. Dollar amounts are very misleading. And so dental supplies, 6 to 7% range is where you should target. Rent and utilities, the range is 4 to 6%. This is an example of, you have no control over the dollar amount once you've signed your lease. 4 to 6% is the range where practices are fully utilized or close to fully utilized. If there's operatories open or if you've expanded, that percentage will be higher. And it doesn't mean that you have bad overhead. It just means that you haven't, your production hasn't increased to the level of your capacity. Lab fees, 4 to 6%. We have some that are 10, 11% and some that are under that. That's a treatment plan philosophy issue. Some people who use CEREC machines are on the lower side. Some people who outsource to more expensive labs are on the higher side. People who do more Crown and Bridge are on the higher side. Again, that's knowing your own practice. Marketing, 1 to 2%. Marketing it's a big thing in my mind. It's not the dollar amount. It's how productive you are. The most effective marketing that I have seen is a well designed internal marketing program. And that doesn't cost a lot of money to do it, but it's a commitment and a culture of doing that. But the main thing is have marketing as part of your practice goals, because if somebody tells me that, hey, I've got too many patients, I'm going to have to turn patients away, I turn marketing off, I will say that's a mistake. It's better to really look at your total base and say maybe it will be better to drop a a low-paying PPO that doesn't have that many patients, because you certainly don't want to give away some good-paying PPO patients or fee-for-service patients because you've turned the spigot off, so to speak, of new patients. So, again, we talk more about that in the webinar. Employee wages and benefits is obviously the biggest category, and this is, this is a general practice. For specialty practices, the rates are going to be about 7 to 8% lower in total. For the general employee, percentage is 17 to 19%, and the hygiene is 13 to 14%. We have hygiene up to 18, 19%, where practices 50%, 45% of their production base is from hygiene department, and that's just fine. It's just math. So the 13 to 14% is usually about 30% of the production is from the hygiene department. And again, and this is a perfect example of if you're looking at dollar amounts, you could look at, okay, what am I paying my people? Should I lower my cost? Should I not give raises? Should I drop benefits? That's a big mistake, because again, or to emphasize that the best way to lower your overhead is to increase your revenue. And that's easy to say, just get more patients. Well, no, there's more to it than that. We know that there's, areas of, treatment plan acceptance and looking at your past patient base. So we get more detail in the webinar. But again, increasing your revenue is the number one way to decrease overhead. So you shouldn't first panic at your level of overhead. You should look, okay, can I get more capacity out of the overhead that I do have? Total overhead range 55 to 65% in the general practice, 8% lower in the specialty practice, because they don't have hygiene, and they'll have assistants, but assistants as a percentage of the revenue is much lower than the hygiene percentage of the revenue. And we'll go into a little bit about the hygiene area in one of the other key factors. Accounts receivable key factors is the next category. And again, there's 3 or 4 different categories. It's really, really important to know each factor before you make any decisions on what to do as far as making things better or improving things. Collection percentage, the gross collection percentage, and that's basically after all write-offs, 80 to 92%. We've got some under 80%. Again, it depends on how people bill. We have some clients that will bill the PPO fee schedule, and the write-offs have already been taken care of, and some will put the full fee schedule in there. So again, the gross is less of a critical factor as is the net. The net 95 to 98%. That is basically how much money you're collecting after your contractual PPO write-offs that you signed up for. So this is what you have control over. So what you send to collections, professional discounts, cash discounts, etc. 95 to 98%. Accounts receivable in days. This range is important. This is basically, you might have heard the term is, you don't want to be a bank with your patients. In other words, hey, just pay me when you can. But also you want to have enough financial policies to get treatment plan accepted. This is one of the measurements we see. So 30 days or less. Now, if I see somebody at 10 days, you might look and say, well, that's wonderful. They're doing great. But 10 days means that they might be collecting the full patient portion at the time of service. And that could be good, but it may not be necessarily. The thing you have to look at is what is your treatment plan acceptance? If your treatment plan acceptance isn't 80, 90%, then that's what one should look at. And if you're, in my experience in consulting with dentists over the years, is that there's 2 main categories of why treatment plan acceptance is lower than it should be. One is how the doctor presents themselves to the patients, the confidence they give when they present the treatment. And number two is the finances. So if they can't afford the procedure, then they're not going to accept. So 30 days or less. Give me an example. A policy that says we have a minimum. Let's say it's $200, $250. It doesn't really matter. With $250 minimum, so everybody's going to pay that at the patient portion at the time of service, and then any remaining balance will be paid in 30 days, and then the final balance in 60 days. So, for example, let's say you have a crown and it's a $1,200 crown, $1,400 crown, $700 patient portion. If your policy is to collect all the patient portion at time of service, there's a lot of good people that can't pay $700 out of their budget right then. But if it's a $200 minimum, and so then there's $500 left, and then they pay $250 in 30 days and another $250 in the next 30 days, you've got your entire $700 in 60 days. One at the beginning, one at 30 days, and one at 60 days. So it's 3 payments. And if they accept that, then the goal is to get the treatment accepted. So 30 days or less, very low, doesn't necessarily mean a good thing. You want to look at your treatment acceptance. Accounts receivable aging range, 20% or less over 90 days. Usually, if you're under 30 days, over 90 days is going to be 20% or less. It's just kind of math. But you want to look at that, just make sure, because anything that creeps up over 90 days, is there something going on in your policies in that at the time of service or in the first 30 days that's preventing you from getting your money and it's creeping into the over 90 days. So it's kind of a check. And so you want to keep an eye on that. Key production related factors, hygiene production ratio 2.8 to 4. So that's a broad stroke, and it depends on a few factors. One is the exam being credited to the hygiene department or the doctor department, doctor production. If it's to the hygiene, which most do not, but some do, it's going to be on the higher end of the range. Do you have expanded duty hygiene to where they're doing extra procedures like anesthesia, fillings, etc., then they're going to be on the high end of the range. Now, this obviously is one of the biggest challenges in dentistry right now, and has been for the last few years, is the hygiene wages demand have gone through the roof recently, and the availability of hygienists is lower. And so people have asked me, well, I just have to accept what I have. And I say, you don't have to accept that. You just have to look at your hygiene department, and you might have to tweak and do things slightly differently. I can tell you from talking with a lot of dentists is that this range for me, minimum was always 3. I dropped it a little bit to 2.8, but the practices, are doing a couple things. It's hard to just, if you do nothing and the wage rate is $65, $75 an hour, it's hard to get a 2.8, 3.0 ratio. And the ratio basically is, if there's $60 an hour, to make the math simple, then a 3 ratio is $180. So they should be generating $180 in collectible dollars, per hygiene appointment per hour. That becomes harder. You can't just do perio diagnosing and have everybody on perio maintenance. It doesn't work that way. So what some have done and been forced to do is, I go back to what a lot of DSOs have done to some of our clients who sold out to DSOs, is they've changed the hygiene appointment from 1 hour to 40 minutes. And so they're seeing like 2 more patients a day in the hygiene department. And most of the dentists I've talked to don't like that because the patient experience is not near as good. The patients feel like they're rushed in and they're rushed out, and they don't get any time with the doc or the staff. So they don't like that. But DSOs are in it for money, and mathematically, if you can get it in 40 minutes and see 2 more a day, then that affects this ratio. So you're going to get two more hygiene visits in a day for the same pay you make. Now, some you do expanded duty. A lot of practices have done that for years, and that takes different, extra credentials, and so it's not like necessarily easy. But a lot have done is, and they've done for years, but more are adapting, is accelerated hygiene, to where they're basically a hygienist is seeing 2 patients in an hour, and doing the cleaning only. They're in between 2 rooms, and they have a designated assistant that's doing the prep and the tear down of the office and the scheduling and the whatever needs to be done in the computer software for diagnosis and so forth. And patients still get their hour appointment. They get to see 3 people instead of 2: the hygienist, the assistant, and the doc. Most of you had great staff. I mean, I don't see that an issue. The people who do it absolutely love it. It's just a culture difference. So if you can do that, basically you get an extra hygiene production in each hours. And the cost of that is the cost of the assistant. So you can easily get into the 3.0 plus range with accelerated hygiene. Something to think about. Doctor associate production per hour. One of the key things when I do a key factor report, one of the things I look at is the doctor production per hour, because I know, again, it's just math. If the doctor is at $400 an hour, I can almost guarantee you their overhead's going to be higher than somebody that's $800 an hour, because again, it's the same staff. It's just more production flowing through in an hour. It's not necessarily even any more patients. It's just procedures being done and so forth. And so I tell people that, hey, in your huddles and a lot of practice talk about what can we do better? What can we do more efficient? A lot of it is geared around the staff. What can the staff do better? I tell my docs, consider flipping that, in a session. Say, hey, what can we do in this practice to make me more productive, make me more efficient? And it's amazing how many ideas your staff will have, and they love the fact that the doctor is humble enough to want to improve themselves. And the end result is, if you increase your doctor production per hour by $50 to $100 per hour, that's almost pure profit to you. It's a little overhead associated with that, but it's almost pure profit. Why wouldn't you do that? So seriously consider that approach. Associate is a little bit lower than the doctor, because oftentimes associates aren't doing as many of the higher fee for service procedures that the doctor, him or herself, is doing. Hygiene requirement. This is just a calculation. Again, we go through more detail in the webinar. But you can look at your patient base and what's your percentage of your patient base that's active adults, and what's your average recall visits. So so your percentage of active adults, you'll break that down between perio and regular. And the regular, it's 2 visits, and the perio, it's 3 to 4. So maybe you do 3.5. You just kind of do the math and say, okay, here's how many visits I need. You can quickly look at it. Are you, is that why you can't get all the hygiene visits taken care of? Because it's very, very obvious. Some people will say, well, the scheduling alone tells me that. Yeah, it does, but what the scheduling doesn't do is if your recall's not working right, you may not be maximizing all the hygiene visits you could with the patient base you have. So it's important to know, based on your base, what should be your hygiene number of hours you should be targeting. Again, this is where some of the practices told me with the accelerated hygiene, essentially they can have one hygienist filling 2 hygienist slots. Some practices on a little larger side will do a hybrid. They'll have some that are doing accelerated and some that are doing regular hygiene. So there's no rules here. It's just looking at different options to increase your production while maintaining your patient experience. New patient factor, again, we say that 15 to 20% of your active patient base should be replaced each year. That will allow you growth and attrition of patients. Patients are going to go away no matter what, whether it's they pass away, they move, whatever reason. It's just inevitable in any business, and so you should target it. This is based on your active patient base, which some practices may not monitor that as closely, but the goal here is to make sure you're focusing on the new patient factor. One thing I go over in a little more detail in our webinar is every month you should look back to your new patients from 6 months ago that came in and find them in your system. Make sure they signed up for a first or second recall visit. That's going to tell you, are you retaining those new patients? Very, very critical. With the competition for dentistry and the saturation and the baby boomers getting older, the importance of protecting your patient base is even more relevant and now. So track that, monitor that. So that basically is the summary, and I got it in actually less than 30 minutes because, again, this is just to give you an idea to kind of wet your whistle, so to speak. And I would say that these are the key factors that I track and monitor. There are many others. The most important thing in my experience is that practices that have items they monitor to see how they are doing are much more successful because they're accountable to a goal. And so set your goals. The ones I picked are ones that I feel give the true picture but are simple to calculate. One thing I have alluded to in here is treatment plan acceptance. I think that is a critical component, but it's not easy for each practice to go into their software system and see what their treatment acceptance is. But we have them look at that as a result of certain aspects of this, because again, getting that treatment plan accepted means getting the revenue. The number one thing you want to do is maximize the revenue you have from your own patient base. And so that is getting them in for active recalls consistently, get their treatment plans accepted, etc. So hopefully this was helpful today. Please reach out if you need anything else. Otherwise, sign up for our webinar, and we hope you become one of our clients. Take care.